hardly deserve. And I'm delighted to be here with my friends from India, like Mohan, Samit, AK, and also with my friends with whom I have a very good rapport, Cerilio and Philip. Thank you very much, and thank you very much to be here. Dear friends, I'm just going to set the stage in next 15 minutes to discuss the various issues that is going to follow. I'll just like to mention that the diabetes today is a very important issue, and we have about 387 million worldwide people living with diabetes, and 46.3%, 47% undiagnosed. Maybe 1 in 12 people take 8.3, and 1 in 2 do not know they have diabetes mellitus. In every 7 seconds, it is said one diabetes has a very fatal complication, and it's going to be, I mean, the amount of money spent in diabetes is not enough, even though it has emerged as the leading cause of blindness, amputation, and kidney failure. And I'll also show in the next 2 slides that 80% of diabetes deaths in Southeast Asia, I'll be specific to that, occurs in the low and middle income countries. And in 2030, it is going to be the 7th leading cause of death worldwide. Dear friends, in contradistinction to data presented here, I would like to share with you a few unpublished data with the permission of the chair, which I am not going to project slides. I must mention here that the prevalence of diabetes today is not in India 8.3%. Mohan's recent research in the CAR study, along with 2 other countries in the Southeast Asia, has shown that almost approaches 20% in people above 30 years of age staying in the metros of the Southeast Asia. One of the studies conducted, which I'll be quoting, which is published, of the ICMR in-depth study. For the people who are new to the study, this is one of the most important diabetes epidemiology study in our country, costing about 250 millions, which is a pan-Indian study. And the data I'll present today is from the phase 1, which is published by Dr. Anjana. But I'll also allude to some unpublished data to say how it can be curtailed. Again, to make a long story short, I must also mention that diabetes today, the challenge of diabetes, is not confined as a diabetes challenge alone. It's a challenge for the obesity, challenge for the cardiovascular disease, challenge for the severe stroke, and challenge for the hyperlipidemia. So therefore, the challenge of diabetes in India, I would like to make it clear, is the most important contemporary challenge before us. Dear friends, this shows the death in the Southeast Asia, and you see the death which occurs in the LMIC, low middle income group, and also see in here the number of deaths adults in the IDF region. You see the number of deaths which occurs in the Southeast Asian region. Now, it has been said that diabetes is a relentless disease. We call it a relentless disease with a relentless advances. And you know, going beyond the usual complications, we know today that about 60% of diabetes also have depression, a great psychological issue. So I have just brought this slide to say that the facets of diabetes mellitus does not confine to physical alone. It also is a relentless disease which probably affects the various other facets of the human life cycle. Now, this is a study which shows the rising prevalence of diabetes in the urban India. You see there is ever rising, 1971, from 2.3 to across, you can see the prevalence is almost approached 18.6 in 2008. And this data I was referring to in 2011, 62.4 million diabetics, which are by the ICMR in-depth study in the first phase in India. And I have projected here in 2030, if you do not take care to prevent diabetes, preventing is not only preventing the primary prevention, even treating the diabetics well, controlling the uncontrolled diabetes with the best available tools in the armamentarium, we are going to have a whopping 101.2 millions. And I have termed this 62.4 to 101.2 million as the preventable diabetes. And I have also termed this as the good area for the good secondary prevention. Now, diabetes and the severe risk, it rises across the spectrum, but we'll find that it is possibly rises from the village to the town to the city, and you see the severe risk of diabetes mellitus is a huge problem in our country today. Now, if you again see the prevalence of the diabetes in the adult population, we have three strategies. We have three stratas. We have 9.2 in the villages, 16.4 in the towns, and 18.6 in Chennai. Dear friends, I just want to mention about a study which Mohan, as the national PI, had just completed. I'm a member of the particular team. Now, in the northeast component of the study, which is going to be published, so I don't focus in the slides, it has been observed that the prevalence is between 5.5 to about 8%. So in the terrains, when there is a lot of walking up and down, when there is a lot of physical activity in the northeast, the diabetes looks to be a little less than elsewhere in the country. But the data will be published subsequently. So therefore, you find that there are issues which can be addressed, that we have a spectrum of diabetes which begins with 9.2%, goes up to almost 20%. This is one of the studies which was done by my colleague Sasank Joshi. It's called Site Studies, Screening India's Twin Epidemic, the diabetes and the hypertension in the outpatient settings in all the major cities across India. To make a long story short, you will find that we have a huge prevalence of diabetes mellitus. I'll just draw attention to this. About 60% were affected by diabetes, pre-diabetes, and hypertension. Pre-diabetes included. See the extent of the problem. And out of this 4528 patients, that about 4634 non-diabetics were on treatment. Mind you, this is the one which was taken in the cities and the metros. So the people getting treatment was about 97%. But if you see the associated comorbid conditions, we have the positive family history, but HbA1c was more than 7 in about 70%. Similar data also has been cited in the ICMR INDAB study, which again chairperson will possibly say sometime in the course of his talk, that we have taken amongst the diagnosed diabetics in the country, known diabetics, called the KD, known diabetics, the control status is awful. Forget about the people who are detected through this screening procedure. So the control has been very bad, and you see the prevalence of hypertension, 60%. We have submitted one of those papers from the ICMR INDAB to the IDF regarding hypertension comorbidity. You see the kidney disease and the dyslipidemia. Now, it is also seen that among those visiting the clinics, the obesity was about 86%, the visceral obesity, thin fat syndrome, and 73% were overweight. This is a study done long back called Diabcare Asia study in 2001, but things have not much changed. In that, done in the metros, 50% had poor control, and about 54% had diabetes-related complications. And you see the treatment pattern. We had 4% on diet, 54% oral AAD, 22% insulin, and as Dr. Samar Banerjee said in this forum 1 minute back, 20% on the combination of insulin and OHA. Now, this is a study which is published in the IJEM about the current status of management, control, and complications, and the psychosocial aspects of patient diabetes in India. We call it Diabcare India 2011 study, and you will observe in this study that we had taken this study. I will not details of this particular thing, and it shows that the HbA1c was about 9 plus minus 2.1. Random blood glucose was 193 plus minus 68, and the fasting plasma glucose was 147 plus minus 49, and the post-mortem glucose was 205 plus minus 65. And you will find the lipid parameters. The cholesterol was 173, HDL cholesterol was 46 plus minus 16, LDL cholesterol 106, and triglycerides 141. Maybe lipid profile was slightly better, and the blood pressure was about 130. But therefore, we found in this study that only 19.7% people with type 2 diabetes mellitus had good glycemic control with HbA1c of less than 7%, and rest 80% had awful diabetes control. Now, it has been also observed in that particular study that if you have the number of diabetic complications, 1, 2 or 3 or 4 complications, you will find the duration of diabetes goes higher. The duration of diabetes goes higher, the longer it's a well-known fact, longer the duration, and therefore it is important, very important to diagnose and treat diabetes early. Now, the practical challenges that we have in diabetes management today, which is going to be addressed, is the treatment. We have the CV complications, and we have Cerulio, who is in the head of the cardiovascular section of the ASD. We have the treatment complexities, we have the deteriorating glycemic control, we have the hypoglycemia, we have weight gain, we have clinical inertia, which Mohan discussed in the morning very well, and we have lot of issues. And there are various factors. There is an economic factor, political factor, the education factor, the fear of insulin, poor self-care skills, lack of social support, and denial of the disease. And we also have no reimbursement, no proper diabetes educator or not diabetic specialist nurses. We have made a change in the healthcare professionals training, but not adequate, and we need a lot of support, both government and non-government, for the diabetic patients. And therefore, we have to have convenience and the lifestyle. Like for the people with diabetes mellitus, we need oral antidiabetics, we need insulins, and for healthcare professionals, we have to say that the people's life to be adapted as far as possible, those who can afford, to the available insulin for the initiation intensification, and when possible the OAD also to be used maximally, and also look into the non-adherence to the insulin therapy. What is most important is possibly education for the healthcare professionals and for the people with the diabetes mellitus. And we must have the tools which are efficient and safe. We shouldn't have fear of hypoglycemia, weight gain. Of course, the mitogenic potential has been addressed very adequately today. The fear of hypo and also physicians' concern about hypoglycemia must be well attended to. Therefore, we have challenges about efficacy, safety, education. We have to have challenges to make it convenient and more close to our lifestyle. And the newer tools are possibly fix that particular issue to a great extent. In India is a very diverse country, and one size does not fit all. We have the people who can afford anything available upon earth. They want to use the most convenient and flexible regimens. There are people who are dependent and who can also afford the bare minimum for the diabetes care. And one has to take care of both to produce the perceptible change in diabetes care in the country. Thank you very much for your patient hearing.